Hi to everyone who is just coming into our webinar. We'll get started in just a moment. Just want to make sure that everybody is on, and I will also be sharing translations for Spanish translations for this webinar in the chat box. Great. Great. I think we're just about ready to begin. Welcome everybody to the RDLA State Advocacy Quarterly Webinar. My name is Rachel Radas. I'm the State Advocacy Fellow, and we are going to be going through a few topics this afternoon. So let's get that here. If you prefer to call into the webinar, you can do so at this number. If you need the webinar ID, it's also listed up here. For those joining on the phone, if you'd like to ask a question, please type in the Q&A box, and one of our wonderful staff here will direct them to the speakers. Reminder for media, we ask that media formally announce their participation and refrain from quoting any of the discussion during the meeting. We encourage media to follow up with participants after the meeting for direct quotes. And there is closed captioning available for all our RDLA meetings. I will be sharing the link to the Spanish translations right now. Here. And then you can just follow this link to access the translations. And here's a brief overview of our agenda for today. So we will do a 1115 waiver overview and state policy updates from Bailey McGowan, who is our state policy manager, and then we will go into Copay Accumulators updates with Randy Kleitz from the Little Hercules Foundation. And then we'll go into drug utilization review and pharmacy and therapeutics community Congress priorities. That will be from Lynn Wilson. And again, please direct all your questions to the Q&A or to the chat box, and we'll have one of our staff answer those for you. And with that, I invite Bailey McGowan, State Policy Manager from the EveryLife Foundation, with their presentation.
Cool. Hi, everyone. It's great to see you guys. So I'm just going to go over what exactly an 1115 waiver is and how you guys can get involved. So 1115 demonstration waivers are the main pathway that states can vary their own state Medicaid program from what CMS, or the Centers for Medicare and Medicaid Services, prescribes as the standard. Typically, the waiver lasts for about 5 years, and the goal is really to expand access to services, try new and innovative programs, and even lately we've seen a sort of surge in behavioral and substance abuse services provided through these waivers. So if we go to the next slide, I think the Kaiser Family Foundation did a really great job at putting this map together that really shows how broadly they're used. Almost every state has an approved waiver, or at least one approved and something pending. So I think it's a really great graphic to show like just how widespread these are actually used. And these services on the graph on the left show, where most of these are targeted at. Again, we see a lot of behavioral health ones in the last few years, but I think that's sort of fitting with this administration's goals on a lot of what we're seeing sort of nationwide, especially through the COVID-19 pandemic. So if we go to the next slide, some examples of this, because like saying that you're going to expand Medicaid services sounds cool, but an actual concrete example is Florida. They expanded their Medicaid program to allow enrollees to access health and behavioral programs that really incentivized healthy behaviors. And they also created a low-income pool to support entities that provide services to Medicaid enrollees, the uninsured and the underinsured. And then Michigan did another fantastic job with expanding coverage for pregnant women and children up to 21 years of age who fell below the 400% of the federal poverty guidelines who were affected by the Flint water system. So again, another great example of how 1115 waivers can be used to expand services and like provide more to their community. So if we go to the next slide, this is a bit more about the process and where states or what states sort of have to do to get there. So usually someone comes up with the idea of, hey, we need to expand our state Medicaid services. We want to change something. And in that process, the state will usually host a variety of public meetings to engage stakeholders in the community in developing their initial draft. And then once the state finally says, hey, we like where this is, we'll host a open comment period where anybody's stakeholders, companies, people who live in the state, people who don't live in the state, can all submit a comment saying what they think about the waiver, if there's provisions in it that they like, if there's ones that they don't like. That has to last at least 30 days. And then they take all of those comments, review them. They can choose to alter their waiver. They can submit it exactly the same. They don't have to do anything with it, or they might not submit the waiver at all. And then once they submit it, once they get that to a place where they like it, they'll send it to CMS, and CMS will eventually say that they have a full or a complete application. And then another 30-day comment period starts where CMS then takes all the new comments on this version of the 1115 waiver, and they sort of analyze those and then make a determination of whether or not to approve the full waiver or parts of the waiver. They might say, you know, this has to come out, but we approve the rest of it. So if we go to the next slide, we have a really recent example. So last year, the Oregon Health Authority drafted an 1115 waiver that initially included a closed formulary that would exclude access to accelerated approval therapies for Medicaid enrollees. Not super great for the rare disease community, especially seeing as, you know, a lot of people either are on Medicaid or Medicaid eligible or could apply for a waiver depending on their state. So, you know, the Every Life Foundation saw this. We submitted a comment during the state's open comment period requesting that they remove the closed formulary provision. So did a lot of other stakeholders. Again, these were other groups, companies, people. And then the Oregon Health Authority took those comments and they made a few changes to their waiver. They took out the closed formulary, but they decided to include something else that would allow the exclusion of accelerated approval therapies. So when they finally submitted a proposal to CMS, we then took advantage of the CMS open comment period and submitted comments there as well. We also provided sort of a primer for RDLA, and we provided a training for some of our other community Congress members to help encourage other people, whether it was through their organization or just as an individual person, to submit comments to that as well. So then if we go to the next slide, this really shows where people can get involved in this 1115 process. So especially during that drafting period, it's really important to, you know, go to those stakeholder meetings to get engaged from the early point before it's even drafted, and let, you know, your health authority know, let even your state legislators know, hey, this is something that could affect our community negatively, or in a different light, it could affect it positively. The Oregon Health Authority we weren't a fan of that particular clause. But then during the open comment period, you can submit a comment, and for the state and for the CMS one as well. And you can find these on a simple Google search. So for Oregon, I found their website by Googling Oregon 1115 waiver, and it popped right up. So it's really easy to get involved in these processes. You know, different states might have coalitions or stakeholder groups that meet to sort of work together on these. So it is an easy enough process to get involved in, and I think just a few voices early on really might have made a difference in this situation. So I think that's all I have.
Great, thank you so much, Bailey. We do have a question in the Q&A box if you'd like to answer live. Was the U.S. Congress Rare Caucus helpful with the Oregon issue?
So because this is and Jamie can correct me if I'm wrong here, but because this is more of a state issue. It wasn't necessarily up to the federal Congress or federal caucus how this proceeded and progressed. It was more of a CMS to state communication issue.
All right, great. Thank you so much, Bailey. And we will move on to our next panelist. We have Randy Kleitz, from the Rare Disease Policy Director from the Little Hercules Foundation, to speak a little bit about copay accumulators and their updates. Right.
Thank you. So we're going to just talk quickly about mostly the work that's being done in coalitions. So for those of you who don't know, copay accumulators is really just simply where you are getting a third-party payer to help you pay your out-of-pocket cost, your copay assistance, and you're putting that towards your deductible or your out-of-pocket maximum. And plans are now designing our benefits to not allow that to count toward your deductible or your out-of-pocket maximum. And so there's been a very active coalition. There's two. There's one, a federal All Copays Count coalition, and then there's a state-based one. And since we're talking about state advocacy, I'm going to kind of just focus on the state advocacy coalition. But it is comprised of members serving the interests of beneficiaries with chronic or serious conditions. There are currently 38 active members of the state coalition. There are a few rare diseases that are very active on the Copays Count Coalition, but I will give you information if you'd like to join us. We talk a lot about how we can educate our lawmakers about the impacts of copay accumulators and how they harm patients. So we do have some resources available that you can get a hold of. Also, I am the lead chair for the Community Congress and the Access Working Group for ERISA plans, self-funded plans. So we do have some resources on the portal there. So you can also see some that's specific to how it impacts ERISA plans, which needs federal legislation, which there is federal legislation now also moving through. It is HR 5801. So again, that's the federal piece. But Rachel, if you can go ahead and go to the next slide, I can kind of talk to you a little bit more about the states. So our state coalition, I am just a member. I am one of the leads for the state of Ohio, but our coalition has been working on just bringing together some model language so we all have talking points. So we really want to educate the lawmakers and have a really clear dialogue on the purpose of why we need copay assistance and that to count towards our deductibles and out-of-pocket costs. So I'll quickly go through these, but really to talk about how cost-sharing assistance is needed because especially us in the rare disease community, we have a lot of high out-of-pocket cost. The high costs impact our adherence to medication regimens. So we know that there are lots of facts out there that say that once a patient has so much cost sharing, they no longer stay compliant with their medication treatment. So that does have a negative impact to overall cost of care. And so, we are trying really hard to make sure that we share our stories to really get to that total cost of care, not just the drug cost. There's coverage requirements that include formulary and utilization management. So all of our state bills that are going around the country right now, they don't impact formulary changes or utilization management at all. So they can still do step therapy, they can still do non-medical switching. Those really aren't impacted by our legislation to try and ban the use of copay accumulators. And really we focus on the fact that this is truly just a double dip. When a plan design is set up and our formulary is set and our out-of-pocket is set, they intend on getting that amount of money from the payer, us being the consumer, and that's how the benefits are designed. Yet now they collect that twice because they collect it from our patient assistance, but they don't actually put that towards our deductible or our copays moving forward. So then we have to pay it again after our assistance is totally tapped out. So there's a lot of lack of transparency. A lot of our patient groups report back to our coalition that they just don't understand that this is happening to them. So that a lot of times a patient doesn't know that their assistance isn't counting towards their deductible or their out-of-pocket cost until they go to the pharmacy counter or order from their specialty pharmacy and are told that they have to pay a certain amount out of pocket when the beginning of the year they did not have to do that. And so that's really the focus of making sure that our legislation and our activities are really educating about making sure that all of our copays count equally. So you can go ahead and go to the next slide. So over the last 4 or 5 years now, we have had legislation that has passed, and I know this is kind of small to actually read, but there have been now 13 states. So the teal colored states are the states that have already passed model language. So those states are protected. Washington being the newest state this year. So Washington on this map is not yet a teal color, but it has passed. And then Puerto Rico has also passed model language. There's active legislation in the states that I have listed there. So if you are from one of those states and you're on the ground and advocacy is a priority for you, there's definitely a lot of work that you could be doing with your coalition. So you can contact me and I can give you the contact in your state if you don't already know who that lead person is, or the two co-chairs of the All Copays Count Coalition for States are Stephen Schultz and Jamie Sexton, and their contact information is there. And so you can reach out to them if you'd like to join the state-based All Copays Count Coalition. And I think that's all I have on this one, and happy to answer any questions. All right.
All right. Thank you so much, Randy. So we have a little bit more information on these copay accumulators. So we have some other state issues. I don't know, Bailey, if you wanted to jump in on these state issues as well.
Hi, sorry, my camera was being really slow to come back up. No, I think that they, and Randy can correct me on this, but I think a lot of them sort of just tie in together with copay accumulators. And so not that copay accumulators are a fix-all, but I think it certainly bleeds into the rest, and addressing one sort of helps address the rest.
All right, great.
Yeah, I think just to clarify too, the utilization management, those are just other things. I know I mentioned a couple of them, but really the thing that I think those of us in the rare community can really talk to is how the formularies really do impact us differently. A lot of times we're in the specialty tier, so our copays or our out-of-pocket costs are so much higher when the opponents of copay accumulator bills, which is usually the plans or the PBMs, the pharmacy benefit managers, talk about this. They talk about coupon use and how coupons are helping patients with their $50 a month copays. Well, most of us who get copay assistance aren't looking at those kinds of costs. We're in tiered formularies that we have out of pockets of hundreds or thousands of dollars a month. So I think that that's the biggest one I wanted to point out on the other issues that states are really talking a lot about. So thank you.
Great. Thank you so much, Randy and Bailey as well. So next up, we have Lynn Wilson from Myositis Support and Understanding Association to be speaking about the Community Congress priorities of the DUR-Pnt, that's the Drug Utilization Review, Pharmacy and Therapeutics Access Group. All right, Lynn, whenever you're ready.
Thank you. Before I get into the wish list, I just wanted to kind of remind everybody that how we got to this point, and it was simply because we understood that that there was a lack of advocacy and patient experts that sit on this board in the at the state level, and a lack of transparency around coverage policies. So what we did was we began to look at some of the issues that were out there in the different states, some of the best practices, some of the things that we knew we wanted on this community wish list, sort of the guardrails that would help us begin to understand how an influence and impact strategy at the state level. So we bucketed, this is our bucket list, into 3 categories, what we call transparency and timeliness, patient advocate expertise, participation, and policy and access. And you see there the list. Now, the caveat on this is that we're all at different places in our state level and in terms of how our advocacy groups are set up. And so some of these are going to be immediate issues that you would probably want to tackle, and some may not. And we're at a point now as we can look through this list, but the issue right now is we need more eyes on this. We need a lot of feedback from all of you out there to let us know if we're on the right track. And then if we're on the right track here, what we want to do is take this list and look for what we call low-hanging fruit, which are those issues that can be addressed in a timely manner and would have high impact for us. And again, this is where there may be a difference of opinion, obviously, because the states are at different levels. So, and in line with that, once we have this list of the low-hanging fruit that we can work on immediately, then we would start crafting a strategy or an engagement strategy around how we would deal with this. So with that, I can go through the list a little bit, and hopefully with the support of Randy and Bailey both, we will, I can answer any questions. So for an example of one that we know is different in different states, one of the things we want is timeliness and transparency around public notice of meetings. And now, of course, this is consistent with the State Open Meetings Act. If you have that, like I'm in Texas, and we have a state law that says that I think it's 3 days or 5 days or something like that. So, and I thought that we could get that to a 30-day time frame. It might not be possible, and it would have to have a change in the law. So, in many places, that's probably not a low-hanging fruit item for people. So we just go through this list. There's most of it is around us having the time to be able to craft a response, be able to get expert speakers or advocates in the meetings so that we can speak. And I think that, I don't know if there's anything else on that list that I would highlight, other than in doing this, we certainly heard a lot of horror stories about what was happening in various states, which was consistent with why we were wanting to look at this from a standpoint of timeliness and transparency. So if you want to go on to the next slide, and I'll just cover a couple of those. Again, this is the critical piece, is that, there's such a lack of advocate and expert participation in these state meetings that it really has become a roadblock for getting the right, the right decision made. And when your experts are thinking they're experts and they're not experts, you're going to run into a lot of problems. And here that, we've got issues around and how we want to do it is acceptance of both oral and written testimony for the patients. Virtual meetings, that's a plus if that is allowed, because those, we all know that virtual meetings are the wave of the future in terms of how we need to deal with some of these issues. What we're seeing is a lack of uniform process across the agencies, no adherence to some of the already embedded processes within the law, and no real point of contact in many states for a rare disease advocacy group. So there's a lot that could be done there. This looks like an area ripe for some movement and influence and getting something done, we hope. So those are the kinds of things we felt were very important to provide guidance on how we can be more impactful at a state level. The third bucket is around policy and access. And we've already talked about some of these, and I can just give you an example of what is important in Texas. I'm working with Crystal Davis, and I'm going to be co-chair of the Access working group there. And I can tell you now that, we're trying to move forward on QALY and newborn and copay. So we have already identified those things in our state that we feel that we can move forward quickly once we have organized ourselves. And most of these we've already talked about, a lot of them, but we felt these were the most significant ones that we needed to be dealing with. And with that, this is a call for action in a way, is that we have, I think we feel like we have worked this as much as we can at this point, and we desperately need to get your feedback, detailed feedback on whether this makes sense for you, if you see that these are actually actionable as far as impact and time and things that are on this list, or things that have been on your mind also. So we can then take that information and start creating some strategy around engagement to give you something to go by in the state, at the state level. And we've put this out there on the portal, but we haven't really gotten a lot of feedback. So we're going to have to figure out how we can get engaged with everybody at a deeper level than we are with just giving you an update, because we don't want to come back in 6 months and be in the same position of not having gotten your feedback so we can move forward. So that's all I really had, mainly just a call for your thoughts and input on this so we can move forward.
Great, thank you so much, Lynn. And I want to remind everybody that this webinar is being recorded, and the recording will be posted at our webpage that is listed in the chat box. So you can go back and view these slides if you'd like to make comments or suggestions for these patient wish list that Lynn described to us. All right, and now we're going to open the floor. I'm going to stop sharing my screen. We do have a couple of questions from Jamie Sullivan to some of our panelists.
Great. Well, thanks. First of all, thank you, Rachel, and thanks to all of our speakers. So we're going to do a little panel discussion now. I invite everyone to input their own questions as well. But I want to start, Lynn covered an overview of items that our Community Congress subgroup that is focused on DUR and Pnt committee engagement, has put together. I wanted to start just by asking Jack if you can share a little bit more of the basics for those who are online that may not be familiar with what the purpose of those committees are and kind of how they operate.
Yeah, thanks, Jamie. So a DUR board, or a drug utilization review board, is a federally mandated program for each state. So each state has to set one up, and it covers their Medicaid programs in terms of drug utilization. So how many drugs are being taken up and what's the cost of them, specifically in your Medicaid program. So this isn't impacting your commercial payers. And they do this in a couple of different ways and across all classes of drugs. So this isn't just a rare issue. This goes into opioids and any other therapeutics or therapies. But they'll look into creating different systems in which they can encourage or discourage drug use. So for instance, with opioids, a lot of states have been looking into different systems to discourage doctors from overprescribing opioids. They're also considering which drugs to put on their preferred drug program, which will certainly impact the price that eventually gets down to the payer. So that's very important. And they're also deliberating amongst themselves and with industry members and with patients, hopefully, usually, about the proper price that should be set on Medicaid. The boards are usually made up of physicians and clinicians. Sometimes advocates are on there as well, but it's usually people in the profession. And then a Pnt board is similar, but it works in the hospital industry. So it's setting the hospital's formulary.
Great, thanks for that explanation. Before we move on off this topic, I'm also curious if you can share. I know you have attended 2 recent DUR meetings, I believe at the end of 2020 or 2021. I'm a year behind, and I'm curious, based on your experiences, observing those meetings, how did it or didn't it align with the items on the wish list?
Yeah, so I got to attend the Oregon meeting and North Carolina at the start of this year. And these observations will certainly vary across state. Every state has their own way of playing. But I found that a lot of our issues that we have with these boards played out in real time, especially to do with access and openness and transparency with the patient community. So on one of these calls, they had what's called an executive session where the board members go and speak amongst themselves, and it's closed off from the public. We don't get any sort of summary from those sessions, really. They also had a packet of detailed information on any of the clinical trials that had gone into the drugs they're using. A lot of data was in there. That was not available to the public. So those sorts of items in terms of transparency and access will be really important for patients to have to fully participate in these meetings. And that was not available to us.
Great. Well, hopefully the wish list and the subgroup that is working on kind of next steps will be able to help work with advocates in the community to make some changes there. So thank you for monitoring those meetings and sharing your experiences. So I'm going to move to Bailey now. Bailey, can you share, this is a state advocacy webinar. Some people may think of Medicaid as, a state program, but one that is also governed somewhat at the federal level. But why is Medicaid involvement, Medicaid policy at the state level so important to the rare disease community?
Yeah, that's a great question. And I think it's just because so many of our of the rare disease population, so many people, qualify for Medicaid. So children qualify for Medicaid. Different states cover different rare diseases, rare conditions, and so there's waivers that people can apply for. So I think that sort of gets at why so many people are affected by this, and why it's important to be proactive as well, because states tend to take cues from other states. So what's going on in one might trickle down to another.
Very good point. We'll throw this to you first, Bailey, but curious others' thoughts as well. But how should people think about getting involved now, or why should advocates think about getting involved, introducing themselves, to their state officials, looking for ways to engage with state health departments before they're in the situation like Oregon, where we're defending or trying to fight against a policy?
Yeah, I think it's a lot easier to play offense than defense. And so if you are proactive in getting to know your state legislators, setting up meeting, telling your story, and as advocates and as patients, your story and your passion for these issues is really your biggest tool in your toolbox. And that's what's most unique to you. So getting involved in that, finding town halls or open engagements are usually posted right on the website. There's typically a calendar from what I've seen. I think that's the best way to really be proactive and then maybe deter from quite getting as far and having to play defense, or you're a known entity when you are playing defense. And so there's some respect and some understanding in that space already.
Great points. Does anyone else have anything to add? Randy, maybe you have some thoughts on the influence that previous established relationships can have in moving policy at the state level?
Yeah, so especially in Medicaid, like there's always an opportunity for them to get consumer patient voices at the table. They have a lot that they have to have patients engaged on. And so making sure that you reach out to the director of your Medicaid program, ask them if they have anybody that, like a medical director that's specializing in rare disease, community support, something along those lines. The example I can give from Ohio is we had met multiple times with our medical director and our pharmacy director for Medicaid, and Ohio changed how we were doing our Medicaid managed care and our straight Medicaid fee for service. And they put together a stakeholder group to really talk through how that was going to impact children with special health care needs. And because we had built a relationship with them when they were asked to put patient voices on those stakeholder groups, we were called and we got to sit through the whole process of how they were going to move our patient population from direct or straight fee-for-service Medicaid into managed care organizations. And every managed care organization in Ohio, we have 5 to 7 managed care organizations over the last 5 or 6 years. And so we were at the table with all of their medical directors. So it was really awesome opportunity. So build those relationships. Don't miss the opportunity to build relationships with the Medicaid directors, the health directors, anybody who's going to touch insurance. Don't forget them. We always talk about the lawmakers, but don't forget the administration too.
Great advice. Anyone else want to weigh in on this?
Yeah, I'd like to say, just to underscore that, is that don't underestimate your own personal connections that you can have, that you already might have and actually don't know. Could be a connection to somebody who is in the state legislature. My husband used to be chairman of the board of Mental Health Association in Houston. And so I've met a few people, and all of a sudden now being an advocate in the rare disease area, all of a sudden some of these state reps, some of the senators, and some of the congressmen that I have met, maybe casually, maybe a little more, have more importance to me because they're the connections that I can make and get to telling the story of what we're trying to do. So don't think that you can't, overcome some of that and do it yourself. You would be surprised, especially in maybe a smaller state too. Couldn't say that in Texas with 30 some odd million people, but you'd be surprised who you might know who knows somebody. It's the 6 degrees of Kevin Bacon concept.
Absolutely. Contact mapping is always a good thing to kind of go through periodically and think about how your connections relate to each other and might be able to help get you in front of the people that you want to be. So wonderful advice as well. Randy, I want to shift back to the topic that you addressed in Copay Accumulators. Like I said, we're on a state advocacy webinar, but I know that this is also a bit of an issue at the federal level. Can you help give some context on why state level action is necessary, even if the federal bill or legislation is put forward?
Sure. So I think the easy answer to that is usually states act faster. And so if we can get a really good momentum, which we have done with 13 states passing the Copay Accumulator ban bills, that makes the federal process go a little bit smoother. The other really great thing is the federal bill on the congressional side, so the House side, now has 31 sponsors, and it's bipartisan support. And a lot of times that's because I know I did it in Ohio. We just passed our state bill last week out of the House 2 weeks ago now. So I reached out to all of our congressional members and said, hey, Ohio just passed their bill out of the House. Will you please sign on as a co-sponsor of the federal legislation? Because the more complex answer is, state legislation is one thing because it can impact the commercially sold products in your state. But back to our work group. So our work group number 3 of the ERISA subgroup, Copay accumulators is one issue that has to do with self-funded plans have more access, and they definitely use Copay accumulators more. And the only way that we can really impact those plans is really through federal legislation, because they have oversight through, actually, it's the strangest thing whenever I learned this, but the Department of Justice is the one that oversees the coverage that we get through self-funded plans. So I think that's kind of the most important part, is even with all of the states, passing state legislation, if we're working for large businesses, I think it's over 80%. I'm terrible with numbers, but it's over 80% coverage for large businesses. Their employees are covered under ERISA plans. It's average 63 to 67%, I think, of our employers on all size employers are now in ERISA or self-funded plans. So I think that's the biggest message that we need, is that we need coverage from both the state and the federal legislation to protect our patient populations.
In case people aren't familiar with what a self-funded plan is, could you explain what that means?
Sure. So that is when the employer themselves is funding all of your healthcare costs, or majority of your healthcare costs. So in commercially funded plans, you're paying a premium. That risk is spread out over a much bigger population. But when your employer is self-funding, they are the payers of your medical cost. And so that really gives them direct access to the cost of your healthcare. So just, it's probably a really simple way to say it, but that's kind of just the easy way to kind of think about it, is that self-funded ERISA plan is backed, almost 100% by your employer.
And the impact of being in an ERISA plan, which you covered somewhat in your response already, but do you explain that what rules that exempts you from, perhaps?
Yeah, it's pretty much, it gets really technical really fast, and I'm not the expert in the technical part of it, but like if a plan that is sold through, or if your coverage is through an ERISA plan, if they're going to cover pharmacy benefits, then they have to cover everything. They can't carve out certain things. However, if they decide that they're not going to cover them as an essential health benefit, then they can carve out certain things. So especially those of us who are in the high cost medical space and specialty pharmacy, we are seeing a trend that a lot of self-funded ERISA plans are carving out certain disease groups, certain treatment options. So if you're using a specialty pharmacy, they can say it's not an essential health benefit and pull that out. Cost sharing doesn't apply if it's not an essential health benefit. So your out-of-pocket cost can be huge. We are actually personally impacted, and my personal copay per month for my son's medication right now is $6,350. They know that we're never going to be able to afford that amount. So they are forcing us into using copay assistance, but then they're not allowing that to count towards our deductible or our out-of-pocket maximum. So those are the kinds of things that are happening. So there's no oversight for most of what we in the rare disease space really felt protected under the ACA, with lifetime and annual caps being gone, the 10 essential health benefits absolutely being covered, not protecting pre-existing conditions. So all of those are really our protections under the ACA and commercially sold plans that aren't typically covered all the time under ERISA or self-funded plans. And I know it sounds so broad, but that's really, it's basics.
No, I think that's a really great explanation. And I think the other thing important to point out is that some people may not even know that they're in a self-funded plan, because even if the company is self-funding it, chances are they're contracting with a insurance company or other third party to actually administer that plan, meaning it looks to you, it might look to you like you have one of the typical insurance companies that you're submitting claims to and you're running it through, but in actuality, it may not be. That company is not paying your claims. So that's the other thing just to keep in mind, is that in the theme of transparency and information and clear information, that may not always be the case here.
Yeah, that's a great point, Jamie, because you'll get a card that says one of the big health plans that you're used to seeing, and you don't realize that you're not insured in the same way that you were before. It's actually just a administrator of the health benefits from your employer.
Great. Well, I know that the EveryLife Foundation and on our community Congress side, we're working through a number of these issues. As you see, they're all interrelated, truly getting down to both state and federal policy solutions now in our various subgroups. And I just really wanted to thank those that are on the call today, as well as our additional subgroup leaders and participants that have been working hard to get to the bottom of these issues, especially tough issues like the ERISA issue, where there isn't a lot of precedent to look to for solutions. So, and how the rare disease community is affected. So I think that, Rachel, I will hand it back to you, but just one last thanks for our speakers and for all of the community Congress partners that have been working on these issues closely.
Great. Thank you so much, Jamie, for all your questions, and thank you to the panelists. I'll go ahead and start sharing my screen again. We'll go back to our slide deck. All right, so I want to announce to everyone our brand new Boston Rare Disease State Advocacy Day that we will be holding in Boston. So this is described as a mini rare disease week. It's a day of action for Massachusetts residents impacted by rare disease to join together and meet their state legislators, share their stories, and help advance the policy priorities of the rare disease community. For this event, this is open to Massachusetts residents only, and we had opened registration last Friday. We are offering travel stipends for those who register by tomorrow, April 29th. So please, if you are interested, or if you have contacts in Massachusetts, please share that over. I will also be attaching a link to the registration. So this is going to be on Thursday, June 9th, from 8 o'clock to 8:30 to 5 p.m. It's going to be a one-day, half-day legislative conference, along with meetings with your legislators in the Massachusetts State House. And a little bit more information can be found online. Again, I'll be sharing that link, and here's a little bit more of where we'll be.
I think we might have lost Rachel. There we go. Okay, well, Shannon, I'm not sure if you're still, if there are any additional slides, but we may have lost Rachel here.
Hi, don't think, I think
think
she,
this is it.
I think that this is it, just
too.
announcing our event in Boston, our very first Rare Disease State Advocacy Day on June 9th. I know that we have a deadline tomorrow is the deadline if you'd like to receive a travel stipend. So make sure to register before then. And we would love for you to share this event with any patients or organizations in your network that are in Massachusetts. So please don't hesitate to share it with others. And if you have any questions, don't hesitate to reach out to Rachel or myself or anyone else on our team. And I guess I will close things up since Rachel isn't with us. Thank you so much for joining us. I see that we have a question. Will it be virtual? So this will actually be our very first in-person event. So this will be in person in Boston. At the State House, we will be hosting the legislative conference in the morning at the Bostonian, a hotel that's about a 10-minute walk from the State House in Boston. And we will be scheduling meetings with the legislators in person at the State House in the afternoon. And there are COVID safety precautions. You can check out our website if you go to stateadvocacy.org. And click on State Advocacy Day on the left-hand side. You'll be able to find more information on the event itself and all of our safety precautions that we are taking since this will be our first in-person event. We're also capping registration and limiting it to a certain amount of people so that we can ensure social distancing at the event itself at the hotel. But if you have any other questions, please don't hesitate to reach out to myself or anyone else on our team. Thank you all for being here. Special thanks to our panelists today and have a great evening. Thank you all. Bye.